will highlight current information on best and promising practices and strategies for cessation with behavioral health populations. The interventions that the panel will be speaking to are focused on both the individual and system level. The panel will be moderated by Dr. Dalton Paxman, who is the Regional Health Administrator for the Mid-Atlantic HHS Region 3, where he oversees public health initiatives for the Office of the Assistant Secretary for Health, U.S. Department of Health and Human Services, better known as HHS. He administers regional public health programs in minority health, population affairs, women's health, medical reserve corps, and the HIV/AIDS Regional Resource Network. He is also a fellow in the College of Physicians of Philadelphia, the oldest medical institution of its kind in the United States. Excuse me. From 1996 to 2000, Dr. Paxman served as the Senior Environmental Health Advisor, Office of Disease Prevention and Health Promotion, providing advice to the Assistant Secretary for Health, Surgeon General on environmental health issues. I'm going to skip a little. Again, the bio's in your book. He also served as the department's liaison to the National Science and Technology Council for the White House Office of Science and Technology Policy. He was a research toxicologist and a postdoctoral scholar for UC Berkeley. And again, you can see very well schooled, very knowledgeable, and I feel very, very lucky to be serving with the Central East ATTC in Region 3, having Dr. Paxman as part of our circle that we work in together. Dr. Paxman, you received his PhD in Environmental Health Sciences from Johns Hopkins University School of Hygiene and Public Health, where he received the Cruz Award for Excellence in Environmental Health Research. So I'm going to turn it over now to Dr. Paxman.
Thank you. Thank you, Renata. Thank you to all of you for being here, and thank you to the Gandhi Institute for holding this really important conference. It's very timely, and I'm sure that you will take from this conference a wonderful wealth of new networks, new ideas, new strategies. I want to thank you all for having me here and listening to me, and I apologize for coming in late. I'm working for the government. I have the joys of working on a government budget during very tight economic times, and instead of taking the expensive Acela train down here, I got the cheap train, and instead of spending the night before, I tried to come this morning, and as a result, I am just arriving off the train. So, but that's it. I saved the government some dollars. So there you go. I'm thrilled to be here. I work in the Office of Assistant Secretary for Health, Dr. Howard Coe, and out of his office came the National Tobacco Strategy, which was an effort to complement the new regulatory authority that the FDA received earlier in the Obama administration, with a coordinated approach across the HHS agency from NIH, CDC, SAMHSA, and from elsewhere. And your conference today is very timely because we're looking at how to transform our healthcare system with the Affordable Care Act now, and how we can integrate all of the different approaches we have to maximize our efforts at tobacco cessation. So I'm in the regional office, the Mid-Atlantic regional office. We cover the states of Pennsylvania, Maryland, West Virginia, Washington, D.C., and Delaware. And I am thrilled and pleased that several of my Region 3 colleagues are here. Dr. Gene Bennett, the SAMHSA Regional Administrator, is here, and Dr. Rob McKenna over here from HRSA, one of the senior public health advisors as well. There's probably others, and I apologize, I haven't run into you yet. But we are here. One of the things that one of our lead initiatives out of our office is the Tobacco-Free College Campus Initiative, which is sort of this conference in a microcosm. Going into a complex university structure, there are so many systems in place. Now, I often joke that while I work in the government bureaucracy, the university bureaucracy is much worse. If anybody has tried to do anything in the university setting, change takes a very long time. And I think some of the things that we're going to talk about here with our next two speakers will play into looking at what kind of strategies are available, but how do we in the system take our approaches and bring in, how do we address vulnerable populations? How do we go after low economic populations? So what kinds of things and what things are effective? So anyway, we're going to have two wonderful speakers who actually have really fascinating presentations. We'll first be hearing from Dr. Steve Schroeder. Now, you've heard from Dr. Schroeder earlier today, so I was given the okay not to read his entire life. We're Jill's first, okay. So we're going to start with Dr. Jill Williams, and I'm going to truncate her bio a little bit. Dr. Williams is a professor of psychiatry and director of the Division of Addiction Psychiatry at the Rutgers University, Robert Wood Johnson Medical School in New Brunswick. The focus of Dr. Williams' work has been in addressing tobacco in individuals with mental illness. And then we'll follow with Dr. Steve Schroeder, who's the director for the Smoking Cessation Leadership Center at the University of California, San Francisco. So we're going to hold off, if it's okay with everyone, we're going to hold off on questions until we've had both speakers, and then we'll have a really wonderful, vibrant question and answer period after that. So with that, Dr. Jill Williams.
That introduction. I'm going to do my best to give a synopsis of updates and innovations in treatment and treatment practices. It is an exciting day for me to be here today at this conference. I was reflecting back when I did my first smoking cessation research study in smokers with schizophrenia almost 15 years ago. So for me, this conference is a long time coming, and I'm very happy to be here and be a part of this. So I'm going to make comments generally about treatment, about cessation. The other disclaimer is it's hard to talk about tobacco treatment without talking about policy and vice versa. Dr. Schroeder is going to follow up and talk more about systems issues, but obviously it's hard to do this without a little bit of overlapping. I'm going to show you first some population data which suggests that this population has reduced success in quitting, or at least reduced quitting, over their lifetime. If you look at the left portion of the slide, we've known for some time that individuals with what we call serious mental illness, these are illnesses like schizophrenia, bipolar disorder, people who are often disabled or have persistent symptoms from their condition termed as serious mental illness. We've known for some time that as a group that they have reduced cessation over their lifetime. The newer information on the right portion of the slide has shown that even with other types of mental illnesses, what we might think of as milder conditions, anxiety disorders, depression, that in fact these individuals also have evidence of reduced cessation over their lifetime. It's not exactly clear why this has occurred. A colleague, Robert West, who's a real leader in the smoking cessation field and heads the smoking cessation for the National Health Service in the UK, presented the equation of smoking cessation at a meeting I recently attended. And it's really a terrific reminder and way of thinking about this issue, that the number of ex-smokers equals the number of people trying to quit times the success of attempts. So what does that mean? It means for this population, it's not clear that it's perhaps true that they have reduced success on a given cessation attempt. But the other portion of the issue could be that they're just making fewer quit attempts. And that's obviously a very important area where we could intervene and where we want the behavioral health organizations to provide greater access to treatment so that we can improve the number of ex-smokers. So I'm going to show you what we know in terms of cessation. Again, this is population data, which also shows if you have depression, you're less likely to quit smoking over your lifetime, and it's shown in different age groups. It's measured as being a former smoker. So people with major depression, less likely to be a former smoker. This is certainly also true in addiction treatment settings, but the good news about addiction treatment setting is that treatment does not seem to have a negative impact on other addictions, which is very good news, because we've had myths in these programs for so long that have been barriers to providing cessation treatment. This study, which was funded by NIDA as part of the Clinical Trials Network, added smoking cessation treatment to treatment as usual. In the smoking cessation group, the smokers were provided 9 weeks of group counseling plus nicotine patch in addition to treatment as usual for their addiction. And the good news about this study is that it didn't affect retention in substance abuse treatment. So if you got smoking cessation treatment, you didn't run from addiction treatment. You were just as likely to be a treatment completer. And there was no negative impact as well on abstinence or craving for the primary substance, supporting that you can provide smoking cessation treatment in these settings without it having a negative impact. In terms of understanding people's likelihood of being able to quit smoking, we need to understand their level of dependence as one factor, which does have important prognostic indicators. Smokers who are more addicted tend to be less successful on any given smoking cessation attempt. Typically in the field, this is done with the measurement of time to first cigarette. How many minutes in the morning till you smoke your first cigarette is a very strong indicator of how addicted you are to tobacco. If you smoke in the first 30 minutes of waking up in the morning, you're at least moderately nicotine dependent. And if you smoke in the first 5 minutes of waking up in the morning, you're severely nicotine dependent. And in fact, studies of behavioral health samples typically show that they have higher levels of dependence. So this is population data showing that people who have depression smoke more cigarettes per day and are more likely to report smoking in the first 5 minutes of waking up in the morning. So as a group, they seem to be more addicted than other smokers. Similarly, it's difficult at times to measure serious mental illness as a population measure, and there's an estimate that's used in population studies called serious psychological distress, which gives us an estimate of serious mental illness. And using national data, we can see that individuals with serious psychological distress are higher on all the measures in terms of higher levels of nicotine dependence. They're more likely to smoke in the first 5 minutes of waking up in the morning. They're also more likely to score higher on a nicotine dependence syndrome scale. So paper measure, biological measure, it doesn't matter how you measure it, they're higher on levels of nicotine dependence than smokers without these conditions. This is a sample of people in addiction treatment in New Jersey, showing the same thing, almost 2,000 smokers who were receiving treatment and addiction treatment services in New Jersey, and you can see extremely high rates, almost 50% of the sample saying that they smoke in the first 5 minutes of waking up in the morning, an indicator of severe nicotine dependence. Some of the research that I've done has looked at schizophrenia in particular. Schizophrenia is one of the most serious mental illnesses that people can experience with often persistent lifelong symptoms. People with schizophrenia have also been noted to be heavy smokers and have difficulty in quitting. This was a laboratory study where people came into the lab first thing in the morning after having not smoked overnight. We verified that their nicotine levels in their blood are extremely low when they come into the lab in the morning, 0. And when we compare a group of smokers with schizophrenia to a group of smokers from the community that don't have mental illness, you can see the difference. In the laboratory setting, they smoked 1 single cigarette. And the red line shows how much nicotine people with schizophrenia are able to get out of 1 cigarette, compared to the blue line, which shows the nicotine intake from a group of what we call community smokers that don't have mental illness. So this is an interesting finding in schizophrenia. No one's exactly sure what this means. It seems to have implications related to the illness of schizophrenia. But I show it to you now because it has clinical significance as well. People with schizophrenia are likely the most heavily addicted smokers we'll see. And in fact, don't be fooled when people report a low number of cigarettes per day. That can be misleading. People are quite good at getting a lot of nicotine out of each cigarette, and they may be smoking a few cigarettes per day because of poverty. And they can be much more addicted than we might think based on the number of cigarettes per day. So again, this has some clinical implications. These are the symptoms of tobacco withdrawal. I know this is review for some of you, but I think that this is incredibly important clinically in terms of a behavioral health treatment setting. So the syndrome of tobacco withdrawal includes sad or depressed mood, insomnia, irritability, anxiety, trouble concentrating, restlessness, and increased appetite. Because of the short half-life of nicotine, these symptoms can emerge just hours after someone's last cigarette. So it's very likely in a behavioral health treatment setting, people are seeing and experiencing these symptoms throughout the day, and it's being missed by the clinical team. This is very likely impacting the clinical management of the person, and unfortunately, even though this is a real syndrome, it's non-specific. It's very difficult to know for sure that it's tobacco withdrawal. There's overlap with other types of medical and health conditions, other withdrawal syndromes perhaps. So it's very likely that in the behavioral health treatment setting, this is missed every single day. It also is important in recognizing that this is what perpetuates some of the myths about the need to smoke in people with mental illness. There's a belief among providers, among families, among consumers themselves, that they need to smoke because of the benefit that they receive from smoking. Smoking calms them or helps them to concentrate. But what they're failing to see is that really they're just going in and out of drug withdrawal. That yes, using drug will temporarily reduce or remove these symptoms, but that's really a never-ending cycle that we need to help people to break free of. There actually is no benefit in terms of having an anxiety benefit from tobacco or nicotine use. Studies consistently show that smoking increases anxiety, for example. So that's an important part of recognizing that syndrome and correctly attributing it in the behavioral health setting. I think that has a lot of implications for treatment. And this is another study from a very good research group out of Wisconsin, which showed that in a large clinical trial of any smokers that presented to their clinic in Wisconsin, that the people who had anxiety disorders had less success in quitting. And again, these are what we think of as mild conditions, people with panic disorder, social anxiety, and generalized anxiety. They're able to quit smoking, but their overall success is less compared to smokers that do not have these conditions. And in fact, in this study, they also reported more nicotine withdrawal symptoms, which you could imagine, having implications for treatment. This has become one of my favorite new studies. I didn't conduct this study, but I think it's quite clever. This study took place in a psychiatric emergency room setting, not often the place where you would think to do a research study. Patients were in crisis, and it included patients with schizophrenia, again, a major mental illness. What they did is, while the patients received their usual treatment for their psychiatric crisis in the psychiatric emergency room setting, they did an experiment where half of the patients, in addition to treatment as usual, received a nicotine patch. The other half actually received a placebo patch, a patch with no medicine in it, to see if it would have any impact on their treatment. When the study was over and they looked back at what had happened to these patients, it turned out that the patients who had received nicotine patch during a psychiatric crisis were significantly less agitated. That had a really clinically significant impact on their care in the psychiatric emergency room, having nothing to do with smoking cessation. And the amount of degree in agitation that they had, the lessening of agitation, was as if they had received a dose of antipsychotic medication. It was a significant degree of agitation that was reduced from a $2 intervention probably less than that, of using a single nicotine patch. Now, you would think that a study like that, where it is a clear benefit, very little risk, would have impacted all the emergency room settings in the U.S., and everybody would have adopted this practice. The study's already 3 years old. I show this in many states, and I've yet to see a place where they've made this a part of standard treatment. This is a slide I borrowed from a colleague, Jody Prochaska. There's a common myth in behavioral health settings that the patients are not motivated, that a barrier to providing treatment, in fact, is the fact that the patients are not interested or not motivated for treatment. This is a compilation showing several studies that don't find that in fact, if you ask patients about their readiness to stop smoking, you find that they're just as likely to report wanting to quit in the next 30 days and in the next 6 months as the general population of tobacco users. So studies don't support that the patients are less motivated to quit. And again, this is quite a nice sampling of different types of psychiatric outpatients, patients with depression, psychiatric inpatients, and even patients in methadone clinics, showing that their levels of motivation, their desire to change this behavior is not very different from other smokers. So important to keep that in mind. Because a barrier, we do have to think about the barriers. Again, I've been doing this work for 15 years, and some days I like to see that the glass is half full. A conference like today and the movement in this country in the last 15 years on this issue makes me optimistic. But I agree with Dr. Schroeder that we're just not doing enough, and we have to recognize what the barriers are. I think a main one is that we still don't value this as a problem among this population, but there's other barriers as well. There's a knowledge deficit among providers of behavioral health. They're not up to date on evidence-based treatments and current knowledge about this problem. There hasn't been a lot of advocacy. There hasn't been adequate reimbursement. As a system, behavioral health, we have been slow to change, to adopt some of these practices. So let me show you something from one of our recent studies. We do a lot of training of behavioral health professionals in training them on tobacco treatment, evidence-based treatment, and as a part of our training practices, we often give people surveys and tests and other things to collect data. And clinicians who were coming to our training in a chart review study we recently conducted, we asked them, what are the barriers that keep you from doing tobacco treatment? And the second most common barrier that they reported, 83% of them said that patients not being interested in quitting was a major barrier to them providing cessation services. And that finding is actually quite similar to what another investigator, Dr. Himmelhoff and colleagues, have recently reported in their study, that 77% of clinicians said that low motivation among clients was a major barrier to providing treatment. So we found remarkably similar results. In our study, though, we had actually conducted a chart review as well of these clinicians, of their practices, and of the patients that they treated. And in the same chart seen by these clinicians, half of the patients said they wanted to quit smoking. So 42% of the patients on these that we looked at in this chart review study said, yes, we do have an interest in quitting smoking, yet the clinicians say the patients are not interested in quitting. So there's a disconnect, even when the patients are saying the right things. In terms of treatment, I think that one of the difficulties that we face right now is that if it is true that patients have higher levels of addiction and need more tailored approaches, smoking cessation treatment has grown up essentially from prevention and primary care, and some of the strategies, although they have proven effective, have been somewhat minimal, especially compared to other types of addiction treatment services. So tobacco treatment has grown up in public health and primary care using brief strategies. And one of the advantages of these strategies is that they have not required a lot of insurance coverage. I think in the future we may need to provide, maybe in addition to those types of services, services more in line with other clinical treatments in the behavioral health setting, where cessation treatments may need to be face-to-face, they may need to be longer and more intensive, and we're going to need to develop strategies to have them paid for better by Medicare and Medicaid. I know there's some talk on the program today about insurance coverage, but we need to expand that in order to be able to help people have greater access to treatment. But I am a believer that behavioral health professionals are actually experts in providing this treatment. Even when we do a training and people say it's the first time they've ever been to a tobacco training, people who work in behavioral health already have the skill set needed to treat tobacco. Counseling is one of the first-line treatment approaches. And the kinds of treatments that work for tobacco cessation are the treatments that these clinical staff already know how to provide. They already know how to do individual and group therapies. They know how to do cognitive behavioral therapy, relapse prevention, and social skills training. So in many ways, they're a terrific workforce to mobilize for treating tobacco. However, again, I think we're going to be in the realm of more intensive treatments, which are typically longer than 10 minutes, according to the PHS guideline, more than 4 sessions. And in fact, the guideline that we use with our evidence-based practices for treating tobacco already says that the healthcare professionals that would be best suited to provide intensive treatment include behavioral health and addiction specialists. So I like to show that to behavioral health audiences and show that they're already listed in the book as the experts for treating this condition to help raise their own self-efficacy, their sense that they can do this work and that it should be within their scope of practice. Okay, so let me just say a few specific things about treatment. What do we know about treatment in these populations? In terms of the need for pharmacotherapy, well, there's no reason not to use pharmacotherapy in these populations. Again, pharmacotherapy is considered a first-line treatment to be used in all smokers, except where there are contraindications, and it turns out there are actually quite few of those. I like to educate psychiatrists that even giving nicotine replacement is not giving somebody a new drug. They've already been on nicotine for many years from smoking, and it's a safer alternative, so it's a very low-risk practice. We should be doing more for giving patients comfortable detox during periods of temporary abstinence, whether that's in the hospital or during a day treatment program. And that would also encourage more people to use pharmacotherapy. Again, I've shown you that there's evidence that these patients have higher levels of nicotine dependence. So in fact, there's probably even a larger role for pharmacotherapy, perhaps compared to other smokers. And again, Dr. Prochaska did an interesting study which showed if you don't give nicotine replacement in the psychiatric inpatient unit, more people sign out AMA. Again, suggesting that people are experiencing tobacco withdrawal also during their psychiatric hospitalization, that giving nicotine, again, is a low-risk intervention that probably keeps them in the hospital longer and allows them to complete their episode of care. We need to share with these providers the new updates in terms of the labeling changes that have occurred with nicotine replacement. Unfortunately, in the U.S., we remain too conservative in the use of nicotine medication, so we need to educate providers that there's no safety concerns with using more than one nicotine medicine at the same time. There's no safety concerns when people smoke or lapse while they're using nicotine replacement, that they should be continued to be offered treatment and try to continue their cessation attempt, and that even longer-term use is also a relatively safe practice. In terms of the use of Chantix or varenicline, there's actually considerable studies that have shown now the safety of this medication. We know that the FDA has a labeling update, a warning, because from case report data, people have reported changes in mood and agitation and even suicide attempts related to the use of this drug. But one of the mysteries is that the research data actually doesn't support this, and it fails to show this association. Again, this was a large analysis of 80,000 people treated in the UK, which did not show that varenicline was associated with more depression or suicidal thoughts. In this study, of course, as you would imagine with 80,000 people, there would be some people who would experience depression or even suicidal thoughts. but the rate of those occurrences was exactly the same whether people received bupropion or received nicotine replacement or received varenicline. So no increased risk associated with that. And in fact, there's even newer studies. This is one of the most recent ones. This comes from a psychiatric journal. They reviewed 17 studies conducted with Pfizer data of patients who had received varenicline in various clinical trials, including 8,000 people. But again, because people have sometimes concern that if we only look at data from clinical trials that are sponsored by pharmaceuticals, that there could be bias. In fact, in this study, they did something clever. They included another 35,000 people, regular American citizens who were treated by the Department of Defense. They combined these into one sample then of more than 40,000 people to try and look at this question. Was the use of varenicline associated with more depression, more aggression, and more suicidal thoughts? And it was not. Varenicline was not associated with higher rate of suicide in this large sample, not associated with higher rate of depression, and not associated with higher rate of aggression. In fact, the rate of neuropsychiatric side effects was slightly higher for the patch. So despite, at this point, pretty compelling evidence that these are safe and effective treatments, we know that they're being underutilized in behavioral health settings. I frequently visit programs, hospitals, where they tell me at the door, we have a no Chantix policy. And that's concerning. Again, this is a potentially life-saving treatment. There's evidence this may be one of the more effective medication treatments we have, and we wouldn't want to systematically ban access among a vulnerable group of patients that may need it the most. Just to show you some more data on varenicline, because since it's the newest medicine, it's the one that's often studied the most these days. This was a study looking at use of varenicline in smokers with major depression. Again, included a large sample, more than 500 people. I believe Dr. Morris was one of the clinical sites for this clinical trial. These were people who had a fair amount of persistent depression. 73% of them were on antidepressants, so a fairly typical clinical sample of smokers with depression. Varenicline was more effective than placebo, as you would imagine, so more people are able to quit smoking if they get the active treatment. But more important for this discussion, there was no evidence that varenicline worsened depression or was associated with serious side effects. So there was no difference. What does that mean? That means that people in these research studies who are taking the placebo come in and tell the clinical investigators each week that they're having abnormal dreams, anxiety, agitation, restlessness, and suicidal ideation. They're on the placebo. So therefore, it can't be attributed to the medication, but it might help us understand how these reports occur. They could be nicotine withdrawal symptoms. They could be agitation related to the underlying mental illness. It's just a more complex picture. And at this point, there's not a lot of evidence that varenicline actually worsens these conditions. This is another clinical trial which was conducted looking at varenicline in smokers with schizophrenia. I was one of the clinical sites for this research study. I'm happy to say varenicline was effective in helping people with schizophrenia to stop smoking. In fact, you can see that the success rate in this study was about 20%. So the take-home message is that this medicine can help smokers with schizophrenia, but the overall success seems to be less than we see in the general population. In the general population, the success rate in quitting with varenicline is probably around 40%, and we're seeing about half that in smokers with schizophrenia. So the treatments work, but it may be that they have a reduced efficacy and effectiveness. The other interesting thing about this study is that we expect people typically in the medication protocol to quit at the end of the first week. That's the way the instructions with the medication say, take the medicine for a week, make your quit date on day 8. The people in this study didn't always follow the directions, so to speak. More of them quit, though. The good news is as the study went on. So we had people quitting who continued in the study at week 2, at week 3, at week 4. So it may be that we would want to slightly alter our treatments to give people a longer lead-in or to allow them more time in making their quit attempt. Again, this was a safety study, so the good news is that there was no evidence that treatment with varenicline worsened the symptoms of schizophrenia. In fact, you can see on this slide, it's really almost a flat line in terms of the level of symptoms that people had during the study. The placebo group also didn't get worse, which is good news, because that means for smokers with schizophrenia, even the action of trying to quit smoking doesn't seem to worsen your illness. So all good news here in terms of safety. And then I just wanted to share with you one of the most recent studies that's been published. This came out in JAMA not too long ago by our colleague Eden Evans. She did an interesting study, again looking at varenicline in smokers who had schizophrenia and bipolar disorder. They did what was called an open label study, which means at the beginning of the study, everybody received access to varenicline and were encouraged to try to quit smoking. At the end of 12 weeks, she took only the people who had successfully quit. And at that point, she randomized them to either continue on varenicline for a full year or to be switched to a placebo. Now, if you look at the placebo group, you can see they had all quit smoking already at the end of the 12-week period, but the relapse rate becomes very high when the medication is discontinued. So her study is answering the question, is longer treatment necessary? Do we need use of medication and other treatment for relapse prevention? And it seems to support that continued use of varenicline for a year results in far fewer relapses than the people who are switched to placebo who had initially quit, supporting the role, again, potentially for longer-term treatment. Again, the safety information from her study was quite good. There was no evidence that varenicline worsened symptoms, that it worsened health, or that it changed weight gain. Again, there's sometimes concern that helping patients to stop smoking will somehow destabilize them, cause them to relapse back to drugs and alcohol, or worsen their mental health. In fact, this meta-analysis of 26 studies showed the opposite. It included studies from the general population in addition to smoking cessation studies and behavioral health samples. And basically in this study, they showed that as a result of quitting smoking, anxiety goes down, depression goes down, stress goes down, quality of life goes up, and positive affect, a measure of just how good you're feeling today, goes up. So lots of indicators of actually improved mental health associated with quitting smoking. Yet we know there's still reduced access to treatment in the behavioral health setting, unfortunately. You might look at this and say, well, some of that's old data, Dr. Williams, and that's a fair assessment, but yet the new study, the one in red, from 9 mental health centers, in fact from Maryland, showed that less than half of the clinicians in these settings were even asking their patients about smoking. So showing that even now, we need to do more, we're improving but not quickly enough. And again, Dr. Schroeder showed this, that policy initiatives have been highly successful at the state hospitals, and I would agree, but only 35% of those state psychiatric hospitals say that they do treatment for tobacco addiction. So it's fine to do policy, but we need to back it up with treatment as well. We can't do one without the other. And perhaps the most concerning to me is this statistic, that less than half of all the substance abuse treatment centers in the U.S. offer treatment for this substance, for tobacco. I know that I'm not really prepared to talk at great length about e-cigarettes. It's been mentioned already. There is a session on this at the conference, but it's probably not the best way to quit smoking, despite what the advertisements will tempt you. Again, my feeling about this as well is if you're in one of these groups of people with behavioral health conditions with very high levels of addiction to nicotine, you're unlikely to be able to satisfy your nicotine need from these products, that they do deliver less nicotine compared to cigarettes. And for most people, I think, who are vulnerable, they're likely to just spend money on them and go right back to smoking. So to conclude my session, there's evidence that behavioral health populations have reduced lifetime quitting, that they have higher levels of nicotine dependence, and a whole host of psychological factors that I didn't even get into that may make it more difficult for them to quit smoking. There's certainly a need for combination approaches, so even though I talked mostly about medication, in fact, the ideal treatment plan for any tobacco user is a combination of medication plus counseling, and certainly that will be relevant for this population. Treatments are safe, and the most current evidence shows that they do not seem to worsen mental illness, and we need to work on reducing barriers to treatment so that these treatments can be delivered more in the behavioral health treatment setting. Thank you.
Steve Schroeder.
While we're getting the slides ready, let me say what an honor it is to share a platform with Joe Williams, who's one of these people who's been doing this good work. I think one of the questions in the previous session commented on how much Jill had been helpful to her local area, and we keep hearing that story over and over. So sort of a Johnny Appleseed. I want to start with a conflict of interest slide, which I should have done the previous one. Some paparazzi got me in Petra, Jordan, next to Joe Campbell. There was no financial conflict. I should also say that our center works with Pfizer to distribute grants. I'm going to come back to that later. We gave a total of $4.5 million in smoking cessation grants to 39 different grantees. But we don't take any money for that. So whether that sort of brainwashes us, I don't know. I certainly hope not. But we have no fiscal conflicts with that. So this is an iconic picture. How many of you have seen this soldier photo? This is in the LA Times after the conquest of Baghdad. And he's handsome, he's battered. The U.S. won, we thought. And he's got a Marlboro close to his mouth. The New York Times did a follow-up front page story on him about a year later. He has PTSD, he's in Kentucky, he's discharged from the service, there were violence issues in his family, and he's sort of a face of the kind of population that we're talking about. Someone who was a 3-pack-a-day cigarette smoker, really wrestling with illness of psychiatric nature, and also been in the service, which has a much higher rate of smoking. So, these are data on smoking prevalence by mental health diagnosis. You can see that in 2007, the ratio with what we called a severe mental illness was 59 or 46%, ADD, ADHD, which I guess would be in the lesser subcategory, 37%. And the more mental health conditions you have, the more likely you are to be a smoker. Looks to me, and Jill, I don't know if you've seen this or not, that as you update the data, the prevalence is going down with these sort of conditions. So again, another argument that it isn't futile, that in fact this population is able to quit smoking. And for the general population, the prevalence of smoking has gone down, as you heard, from 42% to a recent number of 18%. It used to be thought that, well, you're getting the low-lying fruit. Who's quitting? The people who are quitting are the people who didn't smoke much. And so the converse of that is you'd be left with a residue of hardcore smokers. But in fact, we're not seeing that. The number of cigarettes smoked per day by those who smoked was steady at about a pack per day until 1995, and then it's been on a gradual decrease. Now, Joe pointed out that one of the reasons for that may be that it's so costly to buy a pack of cigarettes today, and there's also stigma. And maybe they're getting as much of the bad stuff from the cigarettes by just smoking deeper. But if they're already smoking deeper to start with, down to the bud and taking the bit in, I'm not sure how much more they can do. But at any rate, this just shows you that it's not getting worse. People have thought, wow, the residue of smokers, they're going to be smoking more. And that's not true. So there are myths, and this is really going to recover what Jill has told you. But there are myths, and Jody Prochaska had an article 3 summers ago in the New England Journal of Medicine, sort of taking on these myths and then arguing that they are myths. One is that smoking gives you self-medication, and it's essential. And it's interesting that some of those studies are supported by the industry that makes all the cigarettes. Second, they're not interested in quitting, but you just heard that's not true. They can't quit, and you just heard that's not true. They may have a lower rate of quitting, but they are able to. Fourth is quitting worsens their recovery from mental illness, and that's not true. What Jill didn't show, which I hope you showed us because you didn't have time, is that alcoholics who are able to stop smoking are able to stay sober more. And that's true with drugs too. So it doesn't make the underlying substance use or mental health condition worse. In fact, it might even make it better. And finally, it's a low priority problem. I'm afraid that's not a myth. Well, it is a myth, but also it's a fact that in the clinical treatment world, a lot of people feel that, well, we don't have the luxury of the time to be able to take on this issue because we're dealing with much more pressing issues. So RX for Change, which is this wonderful curriculum that you can get free on the SCLC website, has recently added this slide, which is a slide that tries to kind of give reasons why we should help this population. One, the obvious one, it makes their lives better. Secondly, they live longer and healthier. Third is it improves the effect of the drugs they're taking for mental health problems. Because there's this issue of there's a lot of chemicals in smoke. It isn't the NRT, but it's the chemicals that act on enzymes in the liver to deconjugate medicines. So what shall often happen if people go into a psychiatric hospital, which is smoke-free, and they get stabilized on drugs, and then they go out and start smoking again, their drugs that they're taking for their underlying illness get broken down by the liver much faster. So they look like they're being undertreated. So this is an issue trying to stabilize with the doses. It's socially isolating, it costs a lot of money, and if you quit smoking, your health will get better. There's going to be a session on this, and we just recently had a webinar on it, Jennifer Singletary. I think we had 800 people sign up for this. Turns out, coverage of smoking cessation drugs under the ACA is really complicated. And this is a slide that I prepared, which made it seem simple. But in fact, it depends on what insurance plan they're on, if it's Medicaid, what state they're in, and I don't have the time or the intellect or the knowledge to go through all of this, but you can hear about it more. And it turns out it's really complicated. Jennifer, are you here? So what I worry about is the message you gave in the webinar puts a lot of burden on the providers to have to call the state and find that out, and I worry that the default is just to say, I'm not going to bother. So I hope in your session you will talk about it, because it's very complicated. But I urge you to see the session. So I was asked to talk about systems, elements, and lessons that the SCLC has learned. So first I'm going to summarize the document that Art prepared, which is pretty simple, these elements, but you got to figure out who is smoking and document that in the medical record, or you won't know when they come in the next time to ask about that. You have to train the clinicians and the other staff, and that's the thing that Jill is always able to do. It is helpful in your treatment centers to have dedicated staff who will watch a lot of this, who will be involved in figuring out, hey, let's flag it on their medical record, let's put it in the EHR, let's do that. You need dedicated staff who've been trained in how to help smokers quit. what Kaiser Permanente does is it grades you on customer satisfaction. When you've gone to see a doctor at Kaiser, then they'll send you a questionnaire, you the patient, and say, did Dr. Schroeder ask you about smoking? If the answer is yes, did he help you to quit? So again, nice to build that in. And finally, hospital and clinic policies. So here's this is a distillation of what we have learned at our center. One is, it's really nice to find local champions and to help them amplify their voices. Second, the electronic record is extremely helpful, as you all know, as a way to document smoking status. Put that on the problem list and be a flag at every subsequent visit. Thirdly, the involvement, the training, and the encouragement of office and hospital staff. Fourth, measuring intervention frequency and giving feedback on that so that people in groups who are underperforming can have an incentive to do better. Fifth, as Kaiser does, include health with smoking and customer satisfaction surveys. Sixth, help staff to quit, particularly in a behavioral health setting where the smoking rate is so high. Seventh, policies to keep an environment smoke-free. And finally, peer support and counseling. And Jill didn't have time to comment on that, but a number of organizations have actually trained peers. And it turns out that people with the mental health condition are more receptive sometimes to their colleagues and peers telling them, you know, I went through this and I was able to stop, and it's something you can do too. So as an augmentation to what a clinician does. In our 8 SAMHSA states where we got together people from various agencies and they came upon common strategies to try to drive the smoking rates lower, these were the 4 major themes that they did. One is referral to quit lines. So how to do that? Why? Because it's so much easier in a beleaguered area. Secondly, the quit lines now, thanks to Chad and others, are better able to receive those calls. And third, that they work. The second theme is data. So figuring out what the prevalence is, who's smoking, are there changes. Third, how to communicate, both in any public messages, but also in the settings. And then finally, educating all the various clinical groups. And I must say, it'll surprise you, but North Carolina has been a leader. North Carolina, having had their first summit, has had 2 spontaneous subsequent summits. North Carolina is home of all that tobacco that's being grown and produced. So there are public health people there who are working hard to try to make this different. We have been working with groups in various places. And one of them is Los Angeles County, where we've had some place-based strategies. And they've gotten some CDC grants to try to help smokers quit. And one of the things that they did was to work with LA Pioneers, which essentially was a replication of our SAMHSA grant, where they were tasked, organizations in the community in LA County, which is a county that's larger than most states, were tasked with making policy changes and implementing smoking cessation protocols to make it a smoke-free site. We provided TA with specialized webinars and monthly phone calls, made some personal visits, created a customized toolkit. All of those you can get free of charge from our website. And we conducted site visits there. And then the pioneers, in turn, gave smoking cessation services to their clients and to the staff. Then a second version of this was working with a community transformation grant, where, similar to the previous grant, but this one focused solely on the BH populations, we did similar kinds of things. And did they work? Well, I can tell you that in the first category, or in the more recent one, there were phone calls. We tracked phone calls to the California quit line and found out that from LA County, the number of callers reporting that they heard about this from the clinical settings went up by 18%. And between 2010 and 2011, when we did our CPPW grant, the number of calls we heard about it went up by 229%. Did smoking rates go down in the county? They did, but as a part of a secular trend. So for example, before we got involved with LA County, smoking rates were 14.3%, and now they're down in 2012 to 13.1%, which is a little faster than the rate of falling in the state as a whole. I like to think that we were a part of that, but I can't prove it. This is a national quitline card, which Catherine Saucedo helped to create in our center. And I'm wearing a little replica of it, and I think we have some at our table outside. We deliberately did not brand these. We connect them with the person who makes them, so they give them at cost. They cost about 10.5 cents. They're really slick. They look like a credit card. And what I tell people, smokers, is if you're not ready to quit now, put it next to your credit card. And at some point, so every time you charge something, you'll know about it. At some point, you'll get bronchitis, or you'll think about wanting to see your daughter graduate from college, or going to your granddaughter's, whatever, and you'll be tempted to call those. So they're really helpful. There are about 5 million of them now out in circulation. And different groups, like the American Academy of Family Physicians, have created their own version of it with their own brand. When we talked, so I'll go back, when we began talking about broadening the number of calls from the age population to quit lines, and had early conversations with Sharon Cummins' colleagues at the California quit line, there was hesitancy. They said, you know, we're working really hard, and we're afraid, essentially, this population is going to gum up the works. They're going to be disorganized, they're going to want to get steered into treatment, they're going to take a long time. And our answer was, how do you know they're not already calling? Turns out that they were. And so we've been able to work with the National Alliance of Quitline Consortiums to help to tailor education programs, and Chad Morris has been driving that, to orient the staff at the quit lines to field these calls better. And they work. There are also online help for smokers who prefer using computers over telephones. One reason why smokers like to call the quit line, actually there's several reasons. They're free. You don't have to drive and get a parking spot and all that to go to the clinic. There's anonymity. I remember a couple of smokers who I was trying to help quit who missed their follow-up visits. And when I called them, or they came back later and said, what happened? I said, well, I told them I promised that I would quit on July 12th. And my visit was 2 days later, and I hadn't quit. I was so embarrassed that I didn't want to come. Well, on the quit lines, you're not face-to-face with someone, and apparently smokers like the anonymity that gives. With online services, early studies do show promising efficacy, and I've got 3 websites there that you can look at. So tips for your office. In many states, there's a fax to quit. So how many of you are from states where they have fax? Thank you, terrific. Those of you who are from states that don't, you should lobby them, because they then give the quit line the permission to make a proactive phone call. A carbon monoxide breathalyzer lets the patient see how many parts per million there are of carbon monoxide in exhaled smoke. And for the non-smoker, it ought to be 0 to 5. For big smokers, it can be as high as 50, 60, 70, 80 more. People who have a quantitative band love seeing actually that it went down to a normal range, or even that it's tapered off a little bit as they cut back on smoking. They cost $500, but they'll last a long time. The cardboard mouthpiece is a couple of cents each. question to ask is, when do you have your first cigarette? As Joanne told you. As she also told you, you should approach smoking as a chronic illness. There's one other tip for those of us in the BH field. I mentioned that if you smoke, a lot of the chemicals in the inhaled smoke act on the liver to speed up the breakdown of various drugs. One of those drugs is caffeine. Most smokers drink a lot of caffeinated coffee. So what will happen is that they'll stop smoking. They'll keep smoking, they'll keep drinking that coffee. They're going to double their caffeine rate because it's not being broken down as quickly. They're going to get jittery. They're going to attribute that jitters to stopping smoking, where in fact it might be to a higher caffeine rate. So what you should tell your smokers is you may want to either drink less caffeinated coffee or titrate so that you'll have an equal number of decaf as well as caffeine. And this is, I think, something that can help you with that. So again, asking what we've done. Last year we had our anniversary of 10 years as a smoking cessation leadership center. And we compiled our top 10 milestones. And I want to read them to you briefly. One is the subject of meaning. We've helped, and certainly we don't want to take all the credit for it, but I think we've been a helpful force in mainstreaming smoking cessation into the behavioral health population. Secondly, we've had very productive partnerships with health professional societies to promote smoking cessation. We mentioned American Psychiatric Nurses, American Society of Anesthesiologists, American Academy of Family Physicians, so there are others. The third thing we did is we helped to develop an alternative, a quicker approach to the 5 A's. The 5 A's are wonderful. My thought when we started the center is I would go and meet with clinical groups and tell them about the 5 A's, and they'd say, oh, thank you, Dr. Schroeder, for telling me this, and we're going to do that. It didn't happen that way. What happened is, first they said, what the heck are the 5 A's? And I explained to them, they said, how much time does that take? And they said, we can't afford it. We're just too damn busy. We can't do it. Sorry. So, fortunately, we had a plan B. I said, how about quit lines? What are quit lines? And we'll tell them about that, and it takes only 30 seconds. We could do that. I like to think that some people who start as quit line champions and ask, advise, refer to a quit line, then morph into 5 A's champions, but I don't know that. The fourth milestone was marketing RX for Change, which is this wonderful curriculum developed by 3 pharmacists at UCSF, and they make it available to everybody for free. So you can get it for free if you want it. Go to our website. Wonderful. Some of the slides that I show on my speeches are directly from there. Third, we give our own webinars. We do annual update. We do a communicate about every month. So we'd like to help to build the field. Our collaborative work with SAMHSA is clearly in our top 10. We work in various places: LA County, the state of Washington, the state of Oregon, Indianapolis, also Chicago, where the program is called Second Wind in the Windy City. Makes sense. As I mentioned, we helped Pfizer. They had asked me to be on their speakers circuit, and I wasn't willing to do that because I didn't want to say that we were supported by Pfizer and had a conflict of interest, but we were willing to help them with this grants program where there are a lot of people doing incredibly good work to broaden this field. It's harder to get grants for smoking cessation these days, so that's been something we'd like to do. I mentioned amplifying the voices of the champions, and we've had a lot of articles in the scientific literature, many of them in the premier journals like New England Journal and also JAMA. I have a second slide of a wish list, which I'm not going to show now, but if anybody wants to ask it during Q&A, I can clear it up. So I'm going to close with a couple of slides. One is knowledge gaps about smoking cessation. So most of the studies are supported by pharma, so they don't get back to NRT now because that's been sort of old business. And they don't talk about counseling. And they omit populations. They omit the population that we're here about. They don't study light and intermittent smokers, which which is almost a quarter of all smokers now. They don't deal with incarcerated persons, which is a population that has a very high rate of smoking, or youth, or pregnant women. So these are gaps where we just don't know, especially now. As Jill said, we're probably under-treating in terms of length of time. We don't understand the natural history of quit attempts. Most people who quit cold turkey. And there's an elegant theory called stages of change and pre-contemplation, contemplation. Turns out that may not apply to smoking cessation. And some people, like my father, at age 52, woke up one morning wheezing and saying, "Damn it, Schroeder, who's in charge here? Old Man Tobacco or you?" And quit. And I've had a number of patients who quit on a spontaneous basis. So we don't know sufficient on that. Menthol, I'm sure Phil Gardner tomorrow is going to talk about menthol and e-cigarettes. Menthol is clearly an issue. It may be a reason why people of color who tend to smoke menthol cigarettes more have more cancers in the periphery of their lungs because you tend to inhale it deeper because it's not as, it doesn't feel as hot. Epidemiology of quit-line outreach. And although people worry a lot about gender and ethnic differences, there are no data so far that you treat women or people of color any differently when you're working on how to get them to stop smoking. The e-cigarette, I think I'll quit because I'll skip because we're going to have a great panel on that. So this is my final slide. Where are we in 2014? I won't ask for a show of hands, but most people I know live in a gated community. I can't think of when the last smoker has been in our house, socially. My wife had one friend who turns out was a closet smoker. She snuck outside. She's moved to Georgia. Not because of smoking. She had a granddaughter. But we live in gated communities, so most policymakers don't have the kind of urgency about smoking because it doesn't touch them. As opposed to, think of the consumer movements, breast cancer, autism. Those are very high in people's minds. Smoking isn't in the elite. And it's now marginalized to the poor, the disadvantaged, those in prisons, those in homeless shelters, those with mental illness, those with substance use disorders, plus some of the young people who go to bars and think that they're certainly not going to die, and if they die, it will be from smoking. So in a way, helping rid our society of tobacco has become a social justice issue. Didn't used to be. Both my parents were educated and both of them smoked. But it's true now. It's a marginalized population, which unfortunately in today's political climate means they don't have as much political clout. But people in this room can help that. And what the tobacco industry is doing is fighting a rearguard action at home while they're really looking to increase market share overseas. So again, I thank you for coming here. Thank you for being part of this movement, and we're ready now for Q&A.
I believe we have time for a few questions.
I have a question. Or actually, I want to make a suggestion. One is for Jill. Jill, we have a lot of anecdotal information now with our population that there's a synergistic effect with a lot of the psychopharm that we prescribe for our population that increases the effects of nicotine. So not only are we dealing with how the effects of the medications that are prescribed are ameliorated by the effects of nicotine, but we also think that they increase the effects of nicotine. So, something interesting to think about. And then the other statement I just want to make is I think the next area for policy development, we're very interested in this in our state, is that we don't think anyone who receives a federal health care dollar, any institution who receives a federal health care dollar, should receive monies unless they're tobacco free. That's number one. And then if you take that a step further, and then offer tobacco cessation treatment also. Something to think.
Certainly a great suggestion. Hear, hear.
President, I have a question that I would like to ask. First of all, I would like to say that we have scientific evidence that treating nicotine dependence improves mental health outcomes, and I think that there is no doubt about that. And we have done significant progress in asking for screening for tobacco use and also for promoting policies. Now, my question is, do we have a need to establish standards or protocol for hospitals to treat nicotine dependence?
You want to look at JCHO? I mean, the hospitals often do have standards for that. I'm sure Dr. Schwartz can speak to that.
So, the Joint Commission at one point had smoking cessation as one of its core measures for people with 3 conditions: congestive heart failure, acute myocardial infarction, and community-acquired pneumonia. They found that everyone was gaming the system by just saying that we've done it. So over time, hospitals are scoring at a 100% rate. They then reconvened a group that I was on to say, let's get tougher measures. And the Joint Commission endorsed 4 measures, including finding smoking status, talking about quitting, offering treatment, and then calling the patient after they were discharged. They then made this one of 14 optional measures, quality measures that a hospital could accept, but they can only have to do 4 of them. So essentially, none of the hospitals, less than 50, have yet picked these smoking measures because it requires spending more money. Very cynical in the hospital. It requires spending more money to make those phone calls. So then we ratcheted it up. We said, well, let's talk to the National Quality Forum. The National Quality Forum went through a long process. I have to give the long answer because it's a complicated process. And they say, we endorse the first 3 measures. So then they went, CMS then said, we're going to take a look at these. CMS just recently said, we're going to grade psychiatric hospitals on the first 2 of those measures. That is, ascertaining smoking status and talking about the need for treatment. They didn't yet ascertain, they didn't yet bless the 3rd one, and they didn't do the 4th one at all. For non-psychiatric hospitals, CMS is still thinking about it. So you're seeing pressure gradually being put on, but at a glacial pace.
Thank you.
Hi, Elena Conway, Leahy Health, Burlington, Mass. Thank you. Your presentations were really wonderful, and I have more comments about as things move forward for people at your level that may be able to influence policy. I think it's interesting that for intensive treatment, the recommendation is more than 4 sessions, but what's covered is only 4 sessions per quit attempt. And some, in Massachusetts, for people that are on public insurance, they can get up to 8 sessions, but I think we really need to not set limits on how many treatment sessions are covered for this type of a service. 4 sessions is just not enough, especially for a behavioral health population that may not be appropriate for general group settings. I work at a hospital where we have a lot of free programs that go on month after month, 8 sessions, but a lot of times people with behavioral health issues are really just not appropriate. They may derail other efforts. I think we really need to work on increasing the number of sessions and not putting limits for people to make a quit attempt and be afraid that if they're really not ready, that they've already used up 2 of their sessions, and then what happens? The second piece that I found interesting.
You should come to the session that...
I'll be here all day and tomorrow, but yes, I agree. It's hard to know when to bring these topics up, and in case you guys aren't there, I wanted to make sure to share this. The second piece that I found interesting was the labeling updates, and I prefer language surrounding tobacco treatment rather than cessation or quit attempts. Nicotine replacement therapy, as our organization did go tobacco-free, we really looked at trying to assist people in building confidence in getting through the day without using tobacco. And it's interesting that nicotine replacement products are not there to help people avoid nicotine withdrawal. They're really only approved for treatment and quit attempts, and I think we really need to make some changes on that front too, because when you look at confidence and motivation, which are really the two biggest predictors of success, sometimes you can give people confidence just by saying you really can make it through the day. And if that medication is not approved to help somebody get through the day or to avoid withdrawal, I think it's another place that we could really see some growth.
I mean, I can comment on that. I think you're right. We all wish there was more flexibility. That's a regulatory issue. It's an FDA issue. And unfortunately, what happens is the nicotine medicine, as Dr. Schroeder mentioned, it's been around for so long now. It's not a big money maker. So there's not a lot of incentive for the pharmaceutical industry to develop it further, to go for additional recommendations in terms of relicensing it for temporary abstinence, for example. On the other hand, in medicine, as a physician, I can tell you a lot of medicine is done off-label. Now, maybe I'm cavalier because I'm a prescriber, but it's always a bit odd to me how tobacco cessation treatment, people are so strictly on-label. The rest of medicine isn't like that at all. Everything's off-label. So there's actually nothing to keep us from doing that. That's the way we do most medicine. That's the way a lot of innovation is actually happens. Now, I think it has to do with people's comfort as being non-prescribers and doing off-label, so I certainly understand that. But with the backup of a medical director or somebody, I would say you can do any of those things.
But it is not supplied at a pharmacy. You have to buy a 2-week packet. So if somebody wants to think about going through, it would be nice to sell it like a pack of gum, where you can buy 3 pieces maybe to get through the day and then build confidence in that way. So thank you for listening.
I wanted to know how much emphasis has been put on natural breathing? Because when you think about natural breathing exercise, because when you think about what you're doing when you're smoking a cigarette, that's one of the things that you're doing is breathing. So has that been looked into, or is that clumped in with alternative methods as opposed to using drugs that...
So let me just say that at this point, there's not an evidence base. There's not a lot of research to show that certain alternative therapies are effective for smoking cessation, and that includes a lot of things. On the other hand, I think what you raise is interesting, and there has been some research recently, NIH-funded research to look at that deep breathing stimulates the vagus nerve, and meditation. It could actually have a positive impact, but we don't know that today. It's just beginning to be studied.
So what the Public Health Service guideline does is, on a periodic basis, most recently 2008, they review all the evidence. And a lot of people can get up and testify, I stopped smoking because of acupuncture, or I was hypnotized, or I had mindfulness training, and I'm sure it works for those people. But the evidence has not been studied. And there's a circularity to that, because people like Jill need funding to get studied, and there's no mindfulness pill that's willing to pay her to do that. So it's going to be tough to get an organization to collect those data.
Last question.
Thank you. Christine Schutzman. A couple of things. First of all, thank you for framing this as now a social justice issue. I think it's really hugely important that we approach it that way for both the community's sake and for our own. I think it's a great motivator to put it in those terms. I did wonder if there was any information out there about educating the consumers about the benefit of using NRTs in several different forms. I know that there is some information for the providers, but I know that with the population I serve, the deadly smoking while you're wearing the patch myth is, still out there, and if there could be some education for the general public, I think that might help them be a little bit more receptive to doing combination therapies. And then a question is, I know in Maryland there was, in this last legislative session, a group formed to study the benefits of community health workers and sort of getting them certified to be able to do some of this work. And I'm just wondering if there's any research, I know there's been some little things, but if there's any bigger research about the peer-to-peer approach to smoking cessation, particularly in substance abuse communities?
I'm going to answer the first one, and Jill's going to answer the second one. 2014 will see 3 national television campaigns focused on smoking. I don't know what the content's going to be, but the FDA is going to do one, the CDC is going to do one, the Legacy is going to do one. Karen, do you know whether they're going to focus on drugs at all and what the patient can do, or is it just going to be a more of a general kind of a, you should stop smoking?
Under development.
Under development. So my guess is at the very least it'll drive people. The phones to the national quit line just spiked after the program that the CDC did. If you think that part of the education ought to be there are drugs to help you, now it's not too late to write to Legacy, to write to FDA, to write to CDC and say, think about having a testimonial from someone who uses it. There are other people who say, oh, this is medicalizing smoking cessation, we shouldn't do that. But I'm with Jill. Anything you can do to increase the odds of quitting is great. And she is one of the experts on peer-to-peer counseling.
Thank you. We developed the Choices program in New Jersey, which is really the first peer-to-peer program for addressing tobacco. We do have educational resources that you can get from our website to use for educating consumers, but the whole concept of the program was around this idea of going direct to consumer marketing, that we were having so much frustration changing professionals' behavior that we said, what a great way to do systems change, just bring the message to consumers, because then if they begin to ask their treatment team for treatment, that would be a way to affect systems change. So I think it's a great idea, and power to the people.
I'd like to thank our speakers, Dr. Schroeder, so I'll give them a round of applause.